Hi, good afternoon. I'm Sephora Rosenberg, and I welcome you to today's Grand Round session, which I'm not going to get too far out over my skis to say much about. I'll leave that to a colleague of mine. But teamwork makes the dream work, as I think will probably be thematic in a lot of ways. But I'm going to be introducing today's Grand Round session, and my colleague Joy Choi will be introducing today's speaker. I get the pleasure of reminding us about some housekeeping, including a few things. Today's session is being offered live stream via Zoom webinar. For those of you who are attending online, please feel free to share questions, comments, concerns, things that you'd like us to address in the Q&A section, and our speaker will be more than happy to answer those at the conclusion. Both for those of you online as well as those of you in the room, your feedback is essential, both to saying thank you to our speakers and also thinking about shaping next year's Grand Rounds. So please do complete the evaluation. The added bonus for you is that you get continuing education or continuing medical education credit should you complete that. Last but not least, I would be very glad to introduce my colleague, Dr. Joy Choi, who joins me in the Division of Collaborative Care. Joy is duly appointed in psychiatry and in cardiology and heads up the, I'm going to mess it up, the Integrated Cardiac Transplant Psychosocial something, putting everything to, I'm sorry, I really flubbed that, George. I'm going to be fired. Okay, so I'm going to welcome Dr. Choi up to the podium to introduce today's speaker. Thank you so much.
One more reason for Sephora to be fired. I am not dual appointed. I wish I was. But all right. Yeah, talk for another day. Well, it's truly a pleasure for me to introduce Dr. Adrienne Kovacs today. She is a clinical and health psychologist, and she has dedicated her career to promoting psychological health and well-being of patients with congenital heart disease. She earned her PhD from University of Memphis and completed postdoctoral fellowships in cardiac psychology at the University of Florida and University of Toronto. And after her training, she remained at the University of Toronto for 17 years as a clinician, researcher, and educator in the Division of Cardiology. In 2016, she moved to Portland, Oregon to establish and direct the Behavioral Cardiovascular Program at Oregon Health and Science University. And there she was promoted to Professor of Medicine in 2020. In late 2021, she returned to her hometown of Toronto, Canada, and she there launched Equilibria Psychological Health, through which she provides clinical care and consulting within a private practice setting. And at the same time, Dr. Kovacs continues to maintain academic commitments in mentorship and research with longstanding collaborators. Given her dedication to and expertise in psychological care for patients with congenital heart disease, it is not surprising that she served as the immediate past president of the International Society for Adult Congenital Heart Disease, and she was the first non-physician to do so. She also chaired the 2022 American Heart Association Scientific Statement on Psychological Outcomes and Interventions for Individuals with Congenital Heart Disease, and I must say this is a must-read for all clinicians in the field. She has also been a co-author on several other scientific statements and position papers from the American Heart Association and the European Society of Cardiology. She has authored over 130 peer-reviewed publications and given over 150 invited presentations at national and international meetings in a dozen countries. But perhaps more importantly, to me, she is a kind and genuine person and a wonderful colleague, and a generous mentor to many in the field. I am deeply grateful that she was able to make it to Rochester here today to give this presentation. And without further ado, let's welcome Dr. Kovacs.
That's so nice. That's so nice. Thank you, Joy. No relevant disclosures. Here we go. Okay. It's such a pleasure to be here today. So I've been working with adults with congenital heart disease for about 20 years, and I love this. I love this patient population. They're resilient and impressive, and it's so rewarding to work with them. And I could talk about this for hours. I will not today, but just to let you know, I'm super excited to be here. Just to begin, can I have a show of hands? If you are a mental health professional, can you raise your hand? Okay. If you are a different kind of healthcare professional in a different specialty, can you raise your hand? Okay, a few. If you are employed, staff, have a job, can you raise your hand? Great. And if you are a trainee or learner, resident, fellow, can you raise your hand? Okay, good. Okay, good. A nice mix. I tried to prepare this presentation so that it would have something for everybody. And I really do believe in a team approach to taking care of patients with heart disease, and hopefully that will come across loud and clear as I progress. So I'm really excited today to be talking about psychological outcomes in adult congenital heart disease. And I think we have a responsibility and a tremendous opportunity to do better. So learning aims today, I'll begin by describing key psychological challenges and outcomes experienced within this patient population. We'll talk about strategies to improve well-being within a team-based approach. And I hopefully will convince you of the benefits of an integrated approach to behavioral cardiology. So to begin, because many people are less familiar with congenital heart disease, this is a psychologist's version of congenital heart disease 101. It's the most common birth defect, affecting almost 1% of all infants born in the world, but certainly in North America. It's a very heterogeneous population, so there are dozens of different types of diagnosis. Anatomically, they range from mild to moderate to greater severe complexity. Starting with the 2018 ACHD guidelines in the US, we categorize them not only by anatomical status, but also by physiological class, because that has a little more relevance for their outcomes. We often begin our papers saying something like this: due to significant advances in the diagnosis and treatment in congenital heart disease, now more than 90% of people will reach adulthood, whereas it was about 30, 40, 50% in the mid-1900s. So we've made tremendous gains. However, life expectancy still remains lower for those with moderate or complex defects. Congenital heart disease patients have a significantly elevated risk of neurodevelopmental deficits and disorders, including autism and ADHD. They have an elevated risk of dementia, particularly early onset dementia. And having congenital heart disease does not mean that they don't get other health stuff too. So they develop cancer, and also now that we have an aging population, they're at increased risk of acquired heart disease as well. There are approximately 2.5 million Americans living with congenital heart disease, and about 1.5 million of those are adults. So maybe about 10 years ago, the number of adults with congenital heart disease surpassed the number of children. So this is a rapidly growing population. Sometimes people ask me what is different about congenital heart disease to acquired heart disease. So people with congenital heart disease face these kind of stressors that every cardiac patient might face. So they face new or worsening cardiac symptoms, dealing with medications, remembering to take them, the side effects, hospitalizations, surgeries, cath procedures, imaging, health uncertainty, medical emergencies. They often have device implantations, and if they have an implantable cardioverter defibrillator, they may be dealing with ICD shock as well. They may be dealing with advanced heart failure therapies, so implanted devices, heart transplantation. And at some point, they face declining health status and a transition to end-of-life care. In addition, when we think of our patients with congenital heart disease, they face a unique set of additional challenges as heart patients. They often have traumatic memories of pediatric hospitalizations and surgeries. There are stressors associated with the pediatric ICU environment. They often describe feeling like a miracle and a guinea pig. So they'll say that when they remember being a kid admitted to hospital, that the staff would always bring a huge crowd of medical students just looking at them and listening to their heart, because they felt like they were a guinea pig. They often felt like they were an oddity. They describe feeling different throughout their lives. They transition from pediatric to adult care, so they have been a patient throughout their entire life. And so, as you might imagine, people get adjusted, people get used to the pediatric clinicians, the pediatric environment. Children's hospitals often are friendlier than adult hospitals, so they face that challenge. They often experience worry and overprotection from others, particularly parents or caregivers. As I mentioned, they face neurodevelopmental deficits, and there are often unique considerations for education, work, and family planning. So let's now talk about psychological outcomes in ACHD, and I'll use that acronym, ACHD. This is not new information. So even before I was born, we've known that there are psychological outcomes. So this paper from 1964, the authors wrote, despite benefits derived from these remarkable therapeutic gains, children with congenital heart disease face many difficulties in their efforts toward social and emotional adjustment. So we've known about this for over, almost 60 years. A paper from 1981, this is Dalhousie University on the east coast of Canada. The lifestyle perceptions and responses of a young adult with congenital heart disease would be influenced by all events and interactions that occur during their lifetime. Again, so historically, this is not new information. Coming up to the modern era, this is the paper that we published last year. So it's a scientific statement from the American Heart Association entitled Psychological Outcomes and Interventions for Individuals with Congenital Heart Disease. And for the psychiatrists in the room, we included a table in here about psychotropic drugs and specific considerations for this patient population. We had an adult and a child psychiatrist as part of the writing group here. So we have a list of this information. And just, I can give you a quick preview that none of these medications have been specifically trialed or studied in congenital heart disease. So we have recommendations based on consensus and what we think makes sense. And in our paper, we wrote this: awareness of psychosocial outcomes is necessary for every single clinician who takes care of individuals with congenital heart disease, including those who specialize in heart failure, electrophysiology, so heart rhythm disorders, coronary artery disease, and surgery. And this list certainly includes other specialties, so anesthesiology, obstetrics, imaging, family medicine, and other non-cardiac specialties. And we included this statement in our paper because the editor of the journal said, doesn't this have a narrow scope of interest? But as these patients, they see specialists across the cardiovascular spectrum, it's actually really important that everybody is prepared to work with this patient population. We included this figure to show psychological or potential challenges across the lifespan that can impact psychological well-being in this population. And these are cumulative and interactive. Again, this is what makes these patients different than the adult with acquired heart disease, who often will say, I was healthy my whole life, and then I had a heart attack, or then I needed a pacemaker. So beginning in the prenatal setting, we know that maternal parental distress impacts psychological and behavioral outcomes in children. There are intensive care unit stressors, so it's noisy, it's loud. These newborns are not getting good rest. There are both adverse and benevolent childhood events. They remain at risk for brain injury and other neurodevelopmental insults. Early family life, caregiver stress, financial strain. As children get older, they're developing identities, they're going to school, they're having early peer and social interactions. And we actually know that young people and adults with congenital heart disease are at risk of social cognition deficits. So they're often, we'll describe being somewhat awkward in social situations, being less comfortable with things like recognizing sarcasm and humor. And as they grow older, they face medical interventions, so repeat surgeries, device implantations. There are health disparities, social factors. As they age, there are challenges of adulthood, so employment, family planning. There are some people with congenital heart disease for whom pregnancy is contraindicated because of the significant health risk to the mother. And then they often have aging and mortality issues, so declining cognitive and physical health, end-of-life issues, and some of our patients with complex congenital heart disease will face these issues decades younger than their healthy peers. When we think about pediatric congenital heart disease outcomes, a pooled prevalence from meta-analysis of 16 studies showed that the rates of internalizing behavioral difficulties like depression and anxiety, about 25%, externalizing behavior problems, so defiance, oppositional, 15%. The lifetime prevalence of a psychiatric disorder can be as high as 65% among adolescents with single ventricle congenital heart disease. And that's, I would say, the most complex form of congenital heart disease that we have. So it's significant in this patient population. When we look at adults, according to self-report surveys, elevated depression symptoms range from 6 to 34%. Elevated anxiety symptoms range from 34 to 42%. And these are from studies from around the world. When we look at clinical interviews, a quarter to a third tend to meet diagnostic criteria for a mood or anxiety disorder. And this is true in most of the countries except for Netherlands. So for whatever reason, studies from the Netherlands show that their ACHD folks tend to have similar and sometimes even better outcomes than the general population. I have friends from the Netherlands, and I used to joke, and this was before marijuana became legal in parts of Canada, well, Canada and parts of the US. And I said, well, it's just because they're like smoking all the time. And she said, that's not it. She said, she attributes it to the fact that they ride their bicycles everywhere, and that's why they're doing better. But importantly, from these studies, when we administer clinical interviews, then we look to see who is engaged in, who has a history of mental health treatment. It's between 0 to 30%. 0 to 31% across these studies. So psychological distress is significant, is probably underdiagnosed and certainly undertreated in this patient group. When we talk about patients with single ventricle, the surgery, the main surgery that we do is called a Fontan procedure. So there's been a lot of work looking at outcomes in Fontan patients, Fontan population. A couple of scientific statements that were published, the US one, published in 2019. I was a co-author on that one. We wrote that this is a group for whom the question is typically when, not if, significant medical sequelae will present, and the complex interplay between physical and psychosocial outcomes warrants attention. So it's been identified as a priority in this patient population. This 2020 statement from our colleagues in New Zealand and Australia wrote that people with a Fontan circulation have higher rates of anxiety and behavioral disorders, and there needs to be a low threshold for the provision of mental health care. When you read this, you think, well, everybody must be doing, everybody must be intervening. There must be ACHD psychologists everywhere, and that's not the case. We have increased awareness, but we have not certainly translated that into action just yet. This survey of 57 adults with Fontan circulation living in Australia and New Zealand included an open-ended question. And they were asked, what is your greatest concern as an individual with a Fontan circulation? And the number one issue they reported was fear of death, uncertainty around life expectancy. They said, when will the Fontan fail? And that term is used, and patients do not like it. They're called a failing Fontan. So you're failing Fontan, and nobody likes being called a failure, even if it's with their heart circulation, but we sometimes describe people as that. They want to know how long do they have to be normal, and this health uncertainty can make it difficult for them to make long-term plans. So they have questions like, should I bother going to college or university if I'm not going to live very long? Is it fair to my boyfriend, girlfriend to get married if I may not be here? Should I think about having children or not? So there are a lot of really important and sometimes existential questions that accompany this diagnosis. I'm going to talk to you a little bit about this study we did. So APPROACH-IS stands for Assessment of Patterns of Patient-Reported Outcomes in Adults with Congenital Heart Disease, International Study. I'm on the steering committee, and I always have to read the full name of the study title, but we'll call it APPROACH-IS. And we surveyed over 4,000 ACHD patients in 24 centers in 16 countries. And our measure of quality of life we used was a visual analog scale ranging from 0 to 100, where 0 is worst and 100 is best imaginable quality of life. And we have the working definition of quality of life as life satisfaction defined by the individual, and it can be related to factors both related and unrelated to health. And so I want you to just humor the psychologist for a moment and just think to yourself, what would you rate your quality of life on a 0 to 100 scale, ranging from 0, the worst imaginable, to 100, the best imaginable? And think now, what would be your guess for the average adult with congenital heart disease rating? So in your head, come up with that. Think about your number. You might be surprised to find that the median rating for patients was 80. And I say this, I've presented to smaller groups, and sometimes I have people write down anonymously their number on a piece of paper, and I will say that there has never been an average above 80 from any group of clinicians or researchers with whom I've spoken. And I think this highlights the fact that they are resilient, and it's so easy for clinicians to look at a patient and say, gosh, look at their diagnosis. They're having these health issues. They're having surgery. They must have a lower quality of life. And for me, this really highlights that if we want to know about the quality of life of any individual patients, the only way we can get that information is by asking them. In this study, our questionnaire battery included the Hospital Anxiety and Depression Scale, the HADS, and you get 2 subscales. Total scores on each subscale range from 0 to 21, and scores 8 or above indicate clinical elevation. Here we have the mean scores for the different countries. So patients who tended to, or countries with patients reporting better outcomes, probably not surprisingly, Switzerland, Sweden, the Netherlands. Patients from India, France, and Japan and Taiwan tended to have greater symptoms here, but you can see none of these scores here were above 8, the cutoff. So we actually have a paper in press right now where we're looking at the proportion of patients who met, whose scores were at 8 or higher. So they kind of met that threshold that we would say clinically elevated symptoms. 30% had elevated symptoms in one or both subscales. So 18% elevated anxiety subscale only, 3% elevated depression only, and 9% had both. And I say this because anxiety is often accompanied by depression here, but there were few patients who had depression and isolation. And then again, when we look at the proportions here, so the total sample of 3,800 patients here, because for this particular sub-study, an inclusion criterion was full completion of the HADS. Total sample, 27% met that threshold for anxiety, 12% met that threshold for depression. And France, India, Japan, Canada, we tended to have more people meeting diagnostic criteria. And again, Sweden, Netherlands, Switzerland tended to have reported better outcomes. Then when we looked at, so 8 or above is, I think, mildly elevated, 11 is moderate, 14 is severely elevated. The blue bar here are anxiety scores, and the orange bar here represents depression. We can see here that somewhat linearly, that the worsening anxiety and depression symptoms were associated with poorer quality of life, but much more dramatically for depression symptoms. So less common, but really impactful, really quite significantly correlated with quality of life. And we detected the same pattern when we looked at a 0 to 100 measure, a 0 to 100 scale looking at perceived health status. Once again, increasing anxiety and depression symptoms were associated with worsening health status, but the results were particularly profound for those with elevated symptoms of depression. Among adults with congenital heart disease, anxiety and depression have been associated with more primary care and hospital visits, more emergency room visits, more hospitalizations, and increased mortality risk. And this next slide, by the way, is for you, Dr. Nasra, here. So after a conversation the other day. So this paper is a bit old, and I think that I suspect the results would hold the same today. I just think the dollar amount might be different. So this is Yuli Kim from Penn, and she did this study. I think she was at Boston at that point. And they looked at ACHD surgical admissions. So there were over 3,000 from 42 pediatric hospitals. So these are adults admitted to pediatric hospitals. And they looked at high resource use admissions, and they were defined as those above the 90th percentile for hospital charges. And the dollar amount was around $213,000 or $215,000. And this was in 2011. So we can expect that that number would be even greater now. And they accounted for, obviously, 10% of admissions, but 34% of charges. The mortality rate was higher for these high resource use admissions, so 16% versus less than 1%. In multivariable analysis of risk factors for high resource utilization, depression emerges significant with an odds ratio of 3.1. And so we don't have a lot of data linking depression or psychological functioning and costs and finances, economic impact, but I think this is one study that shows that it is somehow relevant. And we know that in general, our hospital admissions for ASHD patients are becoming more expensive, and there's just more of them. So even if the average was going to stay the same, because there were so many more people entering the ASHD phase every year, it's increasing by millions and billions of dollars. A couple of studies here looking at late cause of death after pediatric cardiac surgery. This one is from Finland, and the purpose of this study was to compare late causes of death after 2 eras of surgery, so 1950s to 1989, and then 1999 and after. And these figures here, this figure is for the entire sample, and the authors concluded that the suicide rate was determined to be similar between study patients and the general population. However, when you look at the numbers, of the 879 patients with late mortality, and they were operated on in this early era, 37 or 40%, 4% of them died by suicide. There was almost 10% of non-CHD related deaths. In this study from Taiwan, they looked at causes of late death in 29 patients with repaired tetralogy of Fallot. Tetralogy of Fallot is the most common cyanotic congenital heart disease. We consider it generally of medium or moderate complexity. 8 of these patients died by accident or suicide, a rate much higher than the general Taiwanese population. I like to pause here for a moment and just emphasize that emotional strengths are also really, really common. And when I talk to patients and when I talk to colleagues and fellow clinicians, I will say that emotional resilience and emotional distress are not mutually exclusive here. So these are what our patients often report. They learn how to cope with uncertainty. In fact, many of them coped really well during COVID because they were used to that. They were used to taking precautions. They were used to this, I don't know what's going to happen idea. They're adaptable in new situations. As a group, they're hilarious. They often have a great sense of humor. They're creative and artistic. They tend to be very kind and understanding of others. They're not judgmental. They often describe being a good observer, feeling grateful, and they will say often that they know what's important in life. So they will often say, I know my values. I know who and what are important to me in life. So switching gears here, now we'll talk about strategies to improve psychosocial well-being within this team-based approach. First of all, I think it's important that everybody who encounters adults with congenital heart disease are mindful of potential neurocognitive challenges across the lifespan. So in infancy, even pre-birth, brain dysmaturation, there's fetal cyanosis and hypoxia, genetic syndromes. Perioperative strategies are important, such as length of ICU stay. There are post-operative complications, so strokes and seizures. Children face extra hospitalizations. They often have school absences, really variable access to developmental services. And in fact, one of the strongest predictors of neurodevelopmental outcome in children, in infants born with congenital heart disease, is family socioeconomic status, because it's whether or not the parents can access early intervention. In adulthood, there are psychiatric conditions. There are acquired comorbidities, and I'll talk a bit about those in just a moment. And then there are the effects of aging on the brain. As I mentioned earlier, adults with congenital heart disease are at increased risk of dementia, including early onset dementia. In 2011, there was a scientific statement from the American Heart Association looking at neurodevelopmental outcomes. They concluded that among pediatric patients with complex disease, there's a distinctive pattern of neurodevelopmental and behavioral impairment characterized by mild cognitive impairment, impaired social interactions, and impairment in core communication skills, including pragmatic language, as well as inattention, impulsive behavior, and impaired executive functioning. And as I always say, these problems do not disappear when somebody turns 18 and they enter adulthood. In fact, they can become even more pronounced. In our adult patients, we know that those with mild or moderate congenital heart disease demonstrate poor neurocognitive outcomes, lower estimated IQ, executive functions and attention are most affected. Abnormalities on brain MRI are common, and as I mentioned, an increased risk of early onset dementia. So what can we do as people who encounter these patients? So in clinical settings, we can increase our awareness. We can start the conversations. We can ask questions like, how far did you go in school? Were you ever held back a year? What were your grades like? Were you ever enrolled in special ed classes? Did you have an individualized education plan or educational assistant? Were you ever diagnosed with a learning disability or ADHD? Have you ever had a formal neuropsych assessment? Are you employed? What's your job? Have you ever had difficulty keeping your job? I can't tell you how many patients I might see in their 30s, 40s, and 50s, and they describe having difficulties in school, and they attribute it oftentimes to their effort. And when I let them know, oh, well, we know that patients have an elevated risk of neurodevelopmental, neurocognitive issues, they're often relieved to know that, because oftentimes nobody has mentioned this to them before. Working in the adult setting, patients would sometimes get transferred to us with no information about any kind of neurodevelopmental history. And oftentimes verbal communication skills are they're very high. And so we need to ask these follow-up questions to get a true sense of their history. We want to optimize education and employment. So include information about education and career planning within transition education. So when people are still in the pediatric setting, we want to help them have realistic educational and career goals. Incorporate neurodevelopmental and psych information in the transfer letter sent to new adult clinicians. Support maximal academic and employment pursuits commensurate with their abilities and their strengths. Oftentimes, it's incredibly frustrating for adults who will say, this is the job that I want to have, but that's not a realistic job for them, but there would be many jobs that would be realistic for them. Advocate for appropriate accommodations in academic and employment settings, and encourage use of available academic and employment services. When we think about neurocognition in the adult setting, it's a little bit different because now we start thinking about risk factors for cognitive decline. Risk factors for dementia include depression, impaired glucose tolerance or diabetes, hypertension, obesity, physical activity, smoking, and all of these factors are amenable to intervention. So oftentimes the best prevention that we can do in the adult setting is actually cardiac primary prevention. Moving on now to talk about psychological outcomes. When I talk with physicians and nurses, I emphasize the importance of engaging mental health professionals within teams, but I also say that you don't have to be a mental health professional to make a difference. So I'm going to share with you some of the information that I share with them. I realize that as many of you are mental health professionals, this may be less new information for you, but I thought it might also be helpful to know some of the messaging that I do share with cardiologists and nurses. I encourage statements to normalize and destigmatize emotional distress. So saying things like, many people with congenital heart disease struggle with low mood or anxiety. I understand that living with congenital heart disease can affect more than a person's heart. It can affect a person and their family in many ways. It's understandable that your cardiac history would have an emotional impact. So oftentimes, I'm the first mental health professional that anybody has spoken with, and they will come to me and I ask them to share their cardiac history, and somewhere toward the end of the intake assessment, at least half of them will say something like, in a nervous voice, so do you think I'm crazy? And I always say that that's not a word that we use, but then I say, not at all. And I say that given your history, given everything you've been through, I would be surprised if there wasn't an emotional impact from that. And when you give them that feedback, you can often see them physically relax. It's just nice knowing that any psychological challenges that they may be experiencing are understandable. As I mentioned earlier, let them know that even patients who are strong, independent, and resilient sometimes struggle with their emotions. And then please let me know if you ever struggle with low mood or worry related to your heart, now or in the future. things can change over time. So you can open that dialogue, because oftentimes in an initial conversation, people may not be ready or willing to divulge that, but maybe they can think about it. And then maybe when they come back for their next clinic visit, they're ready to open up. I'm a big stickler for language, and I think language tweaks are so important and so simple, I would say, to implement. Instead of saying, do you have any questions or concerns? Ask, what are your questions and concerns? So let's assume that people have questions rather than asking a yes or no question. Instead of saying, do you understand this information? Say, am I explaining this clearly? It's our job as health professionals to explain things better. It's not their job to listen better, to pay attention better. And oftentimes people don't like to admit when they don't understand something or they don't grasp something. So I will always say things like, am I explaining this okay? Or should I try, and use different words? Because sometimes I get myself caught up with my language. So let's make it easy for them to ask clarifying questions. Instead of saying, don't worry about this, because never in the history of the world has saying, don't worry about this, ever helped people stop worrying. Say things like, I understand this can be a scary situation. It's understandable somebody would be concerned about this. As a doctor, nurse, NP, PA, psychologist, psychiatrist, social worker, I'm not alarmed by this. And that way they know that within your experience working with this patient population, that you're not particularly worried about that concern. Instead of saying, I know how you feel, consider saying things like, I've heard from other patients and families that patients love it. Patients love knowing what has worked for other folks. I can imagine this might seem stressful. Tell me what this is like for you. Acknowledge unique patient experiences. So instead of saying, I do this all the time, say, I have a lot of experience with this procedure, but I realize this might be the first time for you. So oftentimes, for example, in the pediatric setting, patients will have catheterization procedures under full anesthesia, and then they get to the adult setting and it's a little bit different. So oftentimes they're fearful for that first cath in the adult setting. Let them know that you have experience with this and you're happy to walk them through the process. Offer positive reinforcement. Let them know when they've done something well. So I can't tell you how many times somebody has gone to see a cardiologist and then they see me afterwards and they say, Dr. Nasser said that I was doing really well. Dr. Khan thought that I was exercising. She could really tell a difference. Find something to compliment them on. We all like a compliment. And even if it's something like, I realize how difficult it is for you to get to clinic. I'm really, really impressed that you made it here. I know it's a struggle to do so, so good job. So let them know that they're doing something well. Other important communication strategies. And by the way, when I share these communication strategies, I imagine my patients saying to me, this is what I would like you to let your colleagues know. Ask follow-up patients when somebody tells you that they are anxious. So if a patient tells me that I'm worried about upcoming surgery or I'm afraid of dying, I always say, tell me more. What is it specifically that you're afraid of? Because everybody has different answers to that. Provide realistic expectations, both in terms of recovery from events and also when you're going to call somebody back with test results. I think it's important for patients to let their doctors know and for doctors to ask how patients want to receive information. About half the people want a lot of details. They want to look at their imaging results. They want to see the numbers. And the other half will say, I just want the big picture. Tell me generally what you think I should do. Tell people before you do something to their body. So I work with a lot of adult patients who recall being in the pediatric setting and people touching them and them being unclothed and feeling incredibly uncomfortable. And those memories stick through adulthood. So let people know anytime before you're going to do something to them. Acknowledge the vulnerability, for example, wearing a hospital gown. So I have a friend and colleague in Scotland, and she's really interesting because she's a health psychologist and she also has congenital heart disease herself. And she did a paper really looking at a research study describing the vulnerability that people experience by wearing hospital gowns, and they really haven't changed in decades. So they are not conducive to modesty. Ask, is there anything I should know or can do to make this a better experience for you? And then acknowledge psychological distress, but don't let it dictate diagnosis or treatment. So, and I suspect that many of you working in psychiatry or psychology may be familiar with this, where sometimes it gets easy to attribute physical symptoms to anxiety, for example. So we want to avoid that. And finally, let's talk about why we ought to integrate mental health care within congenital heart disease teams. First of all, the 2018 American Heart Association and American College of Cardiology guideline for the management of ACHD recommended that personnel includes social services and psychological services. So as a field, we think it's pretty important. The Adult Congenital Heart Association has program accreditation criteria. And as part of the criteria, they say that in order to be one of these accredited programs, you need to have a 0.5 FTE licensed social worker, and you need to have a policy plan for referral to mental health services. And I have been vocally critical about this so many times. So I've said, if you mandate it, why not say 0.5 FTE mental health professional, because programs use this to hire staff. And they said, well, we were concerned about the pushback. And so I think that was a major mistake. And there are currently 51 accredited programs, including 4 in New York City, and I think about 29 states. So they're not everywhere. And I will say that there's debate, by the way, whether program accreditation is a good thing, whether certification for ACHD physicians is a good thing, because we don't have enough of them. Recently, it was estimated that we need about 170 more ACHD physicians in the country to meet a ratio of 100 patients per ACHD cardiologist. There are 14 or 15 fellowship slots a year. Half of those get filled. So we're putting out, I'm going to guess 7 or 8 a year, and we need 170. So there are not enough clinicians to take care of these patients. I thought I'd talk a little bit about what I consider appropriate referrals. So this is my initials, so people do it differently. I worked in Toronto and I worked in Portland, Oregon, and I will say that I trained my referring clinicians to let them know what I thought was appropriate to see me. And I always define myself as a cardiac psychologist. So people should be referred to me when there is not appropriate care in the community. So I would see patients with congenital heart disease when that is the primary contributing factor to anxiety or depressed mood, difficulty coping with congenital heart disease or declining health status, heart-focused worry in the context of otherwise positive adaptation, difficulty with the transition from pediatric to adult care, difficulty with adherence, challenges communicating with their clinicians, body image concerns, challenges with social relationships, support with decision-making. So for example, do they want to have this risky cardiac surgery? Do they want an implanted device? What do they think about transplantation? Preparation for surgery or cath procedures, difficulty adjusting to implanted cardiac devices, coping with shocks, and then concerns regarding future health expectations. So I often talk with patients about concerns for mortality, advanced care planning, and end-of-life care. Then here's a list that I consider less appropriate referrals. So if somebody has a chronic mood or personality disorder that requires longer-term treatment and or crisis intervention, I'm probably not the best fit. If somebody has a concern that requires psychiatric treatment or medications, I don't prescribe. The thought of actually being able to collaborate with a psychiatrist is so exciting and exists almost nowhere. If people have substance use problems or eating disorders, they probably ought to be seen by an expert in those. I'm not a neuropsychologist, so I don't do neuroassessment. Any concerns that don't require cardiac psychologists for treatment. And then I think this last bullet point is important, because sometimes there's a clinician or partner who says they need it. Unless the patient themselves is ready for this, best not to refer them. Let them know it's available, but they often do not show for their appointments. It's not good use of their time or the clinician's time. So anytime you're going to refer somebody to a psychologist, psychiatrist, social worker, best to make sure that the patients themselves are interested and receptive to this referral. In our scientific statement, we wrote that the onus on accessing psychological care should not be placed solely on the shoulders of patients and families. It's unkind to say to somebody, well, yeah, gosh, you sound depressed. Go talk to your family doctor and help them sort it out. Or, yeah, I agree that having this major cardiac surgery with significant risk of adverse events or deaths sounds scary, but we don't know how to help you with it. So I think that as teams, we ought to do much better. I see many advantages of an integrated approach. For patients, they get the destigmatization of mental health issues by both patients and providers. So we get to say, it's understandable that this would be troubling. Improved access, they get specialized care. So they get to talk with a mental health professional who knows a bit about what they're going through. So many patients have said, I have tetralogy of Fallot. Have you ever heard of it before? So knowing the language and knowing the doctors and the nurses and the surgeons can be tremendously reassuring for patients. They get the opportunity for truly interdisciplinary care. For the cardiology team, they get skills-based training. So there's an opportunity for them to learn how to communicate appropriately with patients. And I know that's not an issue here because you have a really strong clinician coaching program. They have increased confidence opening the discussion. So it's much easier to say, gosh, you seem depressed, you seem anxious, when they have somebody that they can make a referral to. There's an opportunity to improve the quality of life of their patients. They love that. So physicians like being able to do everything they can for their patients. In fact, sometimes when we talk about moral injury, it's because we can't provide this comprehensive care. And so I think it's actually an important element of clinician well-being. The mental health team, we get access to complete medical details. I like the formal and informal opportunities for consultation, and I love having knowledgeable referring clinicians who can triage referrals. And across these, there's interdisciplinary education, research, and QI initiatives. So in conclusion, adults with congenital heart disease face unique psychosocial stressors across the lifespan. It's thus completely understandable that they have an elevated risk of depression and anxiety. Psychiatric disorders are likely the most common comorbidity, and they largely go undertreated. Our responsibility to these patients extends beyond saving their lives. So it's not enough to get them to live to 5. It's not enough to get them to survive until 18. We want them to have as rich and full lives as possible. I think we have this responsibility, and it's an opportunity to do so. So we want to help them, again, have the best possible psychological outcomes and quality of life, and to live, again, as full and independent lives as possible. And I think we get that from a collaborative model. And thank you very much. I'm happy to take questions. Oh, there's one more? Oh, sorry. No, these are just my backup slides, so. I'm sorry, there might be a QR code coming at the end.
If there's
Hang on,
not
maybe
a
it's at the
QR
end.
code.
Maybe it's, go with, just ignore these ones. I added some yesterday. There we go. Oh, by the way, I'll just show you this one quickly so we can see that there are a lot of states that have no ACHD patients. Anyways, here's the QR code we were looking for.
Wait, there was like a whole other talk in there that we didn't get to hear.
Well, do you know what the problem was? So I met with people yesterday and I thought, oh, I want to add this in. Then I thought, shoot, I have to take things out also. So I just threw them at the end.
Well, please welcome me in thanking Dr. Kovacs. But before we give her another round of applause, we'd love to see what questions are here, both in the audience as well as on Zoom. Yes.
Thank you. Thank you so much. I guess, one thing that pops to my mind is not just thinking about the direct intervention with the patients themselves, but also thinking about potential interventions for the families, both in the pediatric populations, but also when they transition to adults and then the later life issues that can arise. I'm curious if you can speak a little to if there's any current evidence-based recommendations or where we are, I guess, as a field, given that we have such a dearth of kind of providers too.
Yeah, so in fact, we know that the impact on parents begins in the fetal period. So more and more diagnoses are being made in the fetal setting. So when they get fetal echocardiography, So these parents often are stressed out about it beforehand. And so we have data, there are existing data describing the additional stress they face in that setting. We know it has significant outcomes. There are some attempts to intervene even with parents in the fetal setting to offer support. Different programs do things differently. So a lot of programs now have some cardiac neurodevelopmental outcomes programs where they're targeting children and parents. Within, and I mentioned earlier, the single ventricle and Fontan group, there is a National Pediatric Cardiology Quality Improvement Collaborative, NPCQIC, focused on outcomes for Fontan patients, and they have really specific guidelines in the interstage, so between the first, second, and then the second and third procedures they have in infancy to manage this. And those recommendations include providing services to parents. We know, parents and caregivers, we know it's really, really stressful. The access to support is very variable. And one of the things when we think about the transition from pediatric to adult care, historically, we were focused more on the patients themselves. And we said, we need to help them develop the knowledge and self-management skills to become independent when they reach adulthood. And now we realize that that's actually really unfair to patients and parents, because patients, when they turn 18, are not magically adults, first of all. So we want to give them that period of emerging adulthood, so through mid-late 20s, to develop those decision-making skills, if you will. Also, many patients do have neurodevelopmental deficits, so not all of them will be able to become fully independent. So we want to help them become as independent as possible. And it's also very unkind to suddenly say to parents, well, you've done a great job for 18 years, now step aside. Instead, we want to actually continue to engage parents in that transition and in that post-transfer period also. And when you think about it, many adults, many middle-aged and older adults go to medical appointments and they take a spouse or a family member, friend. Our young patients should get to do the same too, and we shouldn't be so critical when their parents are in their room. So I think we're starting to do a better job of supporting parents in transition and also explaining the rationale why we want their kids to become more independent. So one of the things I recommend, for example, is that in the pediatric setting, as developmentally appropriate, beginning in early adolescence, at part of every one of the clinic visits, let's have mom, dad, caregiver step out of the room. And so the young person gets an opportunity to start talking to the doctors on their own independently, and that works really well. However, we need to let parents know the rationale. We want to say, like, let's say your kid is on a school trip and they sprain their ankle and they have to go to the local emergency room. We want them to be able to talk to the local emergency physician and let them know about their heart history. So we want to provide that education to parents too. This is just a recent thing. So I would say within the past decade that we've started to, I would say, be kinder and more compassionate to parents. Great question.
Right over here.
Thank you so much for sharing your knowledge with us and visiting Rochester. I have a question. It was, I'm guessing it was implied throughout your presentation, the amount of trauma that these patients face from childhood into adulthood. And I'm wondering if you can speak a little bit about maybe how you address trauma-informed care, maybe trauma-specific care in how you approach those patients.
Yeah. So first of all, we often get asked even about PTSD. So not many studies have looked at this yet. We did a study in Philadelphia, and I worked with the team there. We administered 2 different measures of PTSD symptoms. So there weren't clinical interviews. And I can't remember which survey was which, but one we asked about specific trauma history related to congenital heart disease, and about 10% reported history of trauma. And then when we opened a separate measure, asked about any source of trauma, and about 20% had reported traumatic episodes there, if you will. And I think that serves as a reminder that our patients also experience trauma completely unrelated or indirectly related to congenital heart disease. It wasn't super high though, and I say it was higher than the average population, but not a lot higher. We're doing a study right now, this long-term follow-up study of patients with another transposition of the great arteries. So we have like a 30-year follow-up study. And that patient cohort also, PTSD, and this is through clinical interview, not way higher than the general population. Oftentimes, though, at patient conferences, patients will stand up and they will say, we all have PTSD. Cardiologists and surgeons will often say, almost all of our patients have PTSD. And I just wanted to say this because it's lower than all of them. But that doesn't mean that they don't have recollections of pediatric events that were traumatic, or even if they didn't meet full diagnostic criteria. I would say that's a great question. I would say that that's something that has emerged more in the past 5 years, and patients are demanding that. I mean, they come and they say, you know, I'm looking for trauma-informed care. So I would say that we have not explored that so much as a field. I would say that that's as an individual clinician, that's on my radar more. And I think that by having an in-depth discussion of what their pediatric experiences were like, that question I asked, one of the items I encourage physicians, nurses to ask is there anything about your health history that you think I ought to know to be able to provide good care for you? That in some ways is a bit of an open-ended question. I've had patients say, for example, that I will never have another exercise stress test because I felt physically assaulted, people grabbing me the last time. People will report having previous hospitalizations where they recall being incredibly vulnerable. They recall being physically violated. So getting a history of those, I think, is really, really important. And then helping prepare the team. And oftentimes with the team, it's, patients sometimes can tell you what they want. They can say things like, this is what will be helpful to me. I really want to know step by step what's going on. If somebody can talk me through it, it will really make a difference. So I would say that I have done a better job asking about this in the past 5 years. So, which I think is something nice as healthcare professionals, that we're always, I think that continual education, I think is really important. I would say another thing we're learning more about now, adverse childhood experiences and the impact of socio-demographic variables on outcomes. And those are things that we really didn't ask so much about. When I was in grad school, it was rarely spoken about. So I think that we're always tweaking the way that we do things in a positive way for patients, I think. Oh, and if I can just make one more comment on that. ACHD cardiologists are a really nice group of people, and they often want what's really best. So although they're adult cardiologists, they often have a bit of a pediatric mentality, and they're often really receptive to things that can make the patient experience better. So it's from a psychologist, a psychiatrist, mental health perspective, the patients are great, but the physicians themselves are often really, really special people.
Just looking to see if there are any other questions here in the room. You have one? You can have one. Yeah.
I'm actually curious how you would ask a question so that you differentiate between resiliency and suppression or avoidance, because sometimes when I see patients with ACHD, their emotional response or affective response to their circumstance with critical illness facing life or death situation seems very discrepant with what I would consider a normal response. But I also want to be mindful that they've been for 3-4 decades, just bombarded with medical adversities that, like, for them, it's become the norm. They always say, well, Dr. Shea, what is normal? Because I don't know what that means. This is my normal. And so how do I appropriately assess for it and also support them? Because I don't want to pathologize things for them that doesn't feel like pathology.
Yeah. My answer for you will be different over the past 2 years than it would have been before. So there's a measure called the Illness Identity Questionnaire, and it's kind of neat, and it's meant to be used for research, but sometimes it's interesting to explore clinically, and sometimes I use it to look at avoidance. So I think there's about 18 or 20 questions, and you get a sense of whether somebody falls into one of 4 categories. There's avoidance, engulfment, acceptance, and enrichment. And I started using it because sometimes people will rebel against the acceptance word. So sometimes they'll say, I shouldn't have to accept this, I don't want to. So when you look at the individual items, it kind of helps people understand what acceptance means. And it doesn't mean that we give in and we stop aiming for the best outcomes possible. But there are also some items there that get to avoidance. And so I don't actually usually administer the survey. I just explain to people, I'm half clinician and half researcher, and I find the items here can sometimes explain things a little better than I can. And so, questions about, I avoid thinking or talking about my health, for example. So oftentimes I will use this measure as a springboard to having a different conversation. Because again, and that's true whether we're thinking of all four of the potential categories. So some people will avoid doing everything. There are other people who their diagnosis does kind of engulf who they are, and it dictates all of their decisions. So it's really difficult for me. And when I see somebody in there who's 30 years old and they say, I wanted to go to school, but I couldn't because of my heart disease, or I wanted to go into the military. And once I found out I was ineligible, I did nothing else. And so they define themselves. So we sometimes can use this to have a healthy definition. Again, even thinking about acceptance, which I would say is the goal, and then enrichment. And sometimes people really struggle with that. So they'll say, I shouldn't be expected to have this, growth experience from it. So, but sometimes when you look at the individual items, it can be helpful. So I would say lately, I find that having this list that I can discuss with them, and then they can sometimes identify themselves, or some of the items can resonate with them as well. We discuss the difference between avoidance and distraction sometimes, but just lately I've been sometimes bringing that measure into conversation, and it goes well when I'm not administering it, if you will. And as many of you may know, patients are always really critical of these self-report surveys, so they get to be critical of the item construction and the language and things like that. So I've been doing a bit of that lately.
Well, I'm just mindful of the time. Very grateful to Dr. Kovacs, grateful to all of you for your attention. Thank you so much for being with us. I would make a comment about the snow, but you're from Toronto, so you probably have it worse than we do.
It's okay.
But thank you again for being with us, and thank you all for coming.
Thank you for having me.